Okay, guys, let's settle down.
All right, everybody pay attention.
The roll is going around, so please sign your initials if you're here. You can't sign them if you're not here. Okay, yesterday we were talking about obesity, and we began talking about the diagnostic test for a workup for a person who is obese. And so another two tests that they look at, or two more tests that they look at, are hemoglobin and hematocrit. And of course that's part of the CBC. I hope by that now you guys know that. And if they're decreased, that could indicate anemia. And many times obese people are anemic because they're not eating the right kinds of foods. They also look at the visceral proteins, the serum albumin, the thyroxine binding prealbumin, and the transferrin. All of those give you some sense of how nutritionally stable the patient is. But the best one is the thyroxine binding prealbumin. It's the most sensitive indicator of nutritional status. I'm sorry?
You said which one's the best one?
The thyroxine binding prealbumin. It's the most sensitive indicator of nutritional status. Transferrin is also a sensitive indicator of nutritional status. So they all will give you some sense of how nutritionally stable the patient is. And then, of course, we look at the total lymphocyte count. Because the patient might have some kind of infection going on, and if it's elevated, that could indicate an infection. Okay. So, there's different ways to manage obesity, and one approach is, of course, diet programs. And there's all kinds of diet programs out there. Some of them are good, and some of them are not good. The short-term fasting programs, first of all, before I start that, let me say that when you're dieting, the diet that you are on should be nutritionally sound. And some of these are not nutritionally sound. Short-term fasting programs, those are really not nutritionally sound. They don't produce permanent benefits. In other words, most of them regain their weight when they do these. Very low calorie diets. Again, these are not the best. This is not the best approach. There's two types. There's one that's protein sparing modified fast, and when you need protein in your diet. The other one is a liquid formula diet, but most of these diets are 200 to 800 calories a day, and that's not nutritionally sound. 200 to 800 calories a day. They're going to lose weight, but they're going to gain it back. If they go on this kind of diet, they need a cardiac evaluation before they start the diet. And they also need close supervision. A cardiac evaluation. Nutritionally balanced diets. These generally have at least 1,200 calories a day in them. And they have an appropriate distribution of carbohydrates, proteins, and fats. Weight Watchers is an example of that. I'm not pushing Weight Watchers, but it is an example of that. And along with Weight Watchers, not only is it a nutritionally balanced diet, but they also have education that goes along with it. And then your unbalanced low energy diets. One example of that is the Atkins diet. The Atkins diet is a low carbohydrate diet, and that is not a nutritionally sound diet. What happens when you don't take in carbohydrates? Where do you get your energy? Does anybody know? What does your body break down?
Ketones.
It breaks down fat, but what else does the body break down?
Muscle.
Protein. You need carbohydrates for energy. And if you go on a low carbohydrate diet, then your body's going to break down protein for energy, because your carbohydrates are for energy. And these people usually gain their weight back. There's conflicting scientific data as far as these unbalanced low energy diets, so they're not suggested for the most part by physicians. And then there's novelty diets. Has anybody ever heard of the grapefruit diet? The Hollywood diet. There's a diet called the cookie diet. These are These are nutritionally unstable. They're inadequate. The premise behind this is that certain foods will increase the metabolic rate, and because of that you will lose weight, but they're not proven. And if they do lose any weight, it stops after they stop the diet. So the only one up there that's good is a nutritionally balanced diet. And an example of that, of course, is Weight Watchers, which I told you about. Okay, so nutrition is really important. They should collaborate with the nutritionist. The nutritionist will sit down and talk to them about the foods they prefer, about what their eating habits are, if there's anything as far as culture that's important as far as their diet, and the nutritionist will develop a nutritional plan for them. They create a diet plan to create a 500 to 1,000 kilocalorie deficit a day. If they have a 500 calorie deficit a day, they'll lose about 1 pound a week. If they have a 1,000 calorie deficit a day, they'll lose 2 pounds, about 2 pounds a week. The best way to go about losing weight is to be on a diet where you'll lose about 1 pound a week. 1 pound a week. So they're low kilocalories, so they're low in calories, they're low in fat, and they're high in fiber. You need fiber to get that food through the GI tract so that you won't have a problem with constipation. If a patient has a BMI greater than 30, many times or sometimes I do put them on a very low caloric diet. What happens when they lose weight? If they lose 5 to 10% of their weight, then what happens is they have better control of their blood glucose level. They have better control of their blood pressure, and their cholesterol will decrease. Decreased blood pressure, decreased blood sugar, and decreased cholesterol. This is a critical element of losing weight, exercise. Exercise and controlling what you put in your mouth. Those are the two critical elements of weight loss. These people should be under the care of a physician. Don't ever suggest to anybody that they exercise, because that should come from the physician. They need to be under the care of a physician. Walking is one of the best aerobic exercises they can do. And it's cheap. You don't have to go to the gym. You don't have to walk on the treadmill. You don't have to do any of that stuff. You can just walk. Walk around your neighborhood. Walk wherever you want to. 30 to 40 minutes, 5 times a day. I know some of y'all have been walking around. I noticed that the other day around in here, all the way around it's like a rectangle. And that's good. That's good. Okay, exercise helps preserve lean body mass, decreases your waist circumference, decreases your waist to hip ratio, and remember those are indicative of the risk of cardiovascular disease. Helps you lose weight. Now we're going to talk about these medications that you can use for weight loss, but I'm going to tell you they're not for long-term use. They're not for long-term use. The only one, the orlistat, Xenocol, is a lipase inhibitor. These things have bad side effects, so that's why they're not, you shouldn't use them for an extended period of time. This one is given to patients with a BMI of 30 or greater, or if they have risk factors such as hypertension, diabetes, hyperlipidemia. However, they don't lose a lot of weight. It produces only a modest reduction in weight. So my feeling is, why use them? But some people do use them. You have to take this with meals that contain lipids. It has to be taken with a meal that contains lipids, in other words, fats. It's only effective if they take it with a meal that contains lipids. But the side effects is that they have flatus, gas, oily stools, fecal urgency. In other words, they have to go to the bathroom and they have to go right now. And abdominal pain. One problem with this drug is that it interferes with the absorption of fat-soluble vitamins, and you need your fat-soluble vitamins. And it also interferes with the absorption of Coumadin if you're on Coumadin. So if you have a patient that's taking this drug and they're on Coumadin, then the physician needs to be checking their PT and their INR. Everybody knows what that is? Yeah. PT and INR? Okay. Now your anorexiants, I'm not even going to give you the names of those, but I'm going to tell you what they do, because these block our feeling of hunger. They block our feeling of hunger. They have serious side effects. They're used only for short term. And they're only used with patients that have a BMI of greater than 30, or if they have comorbidities like hypertension, diabetes, hyperlipidemia, those things. They have risk factors. Then the bottom line I'm going to tell you about these medicines is that weight gain is common after they get off these medicines. Okay, another thing that's important to weight loss is behavior modification. They've got to change their behavior. They've got to change their lifestyle. It's critical to them losing weight. One of the things that they can do is keep a food record and write down everything that they've eaten. And so that gives them a visual of what they've eaten that day. They need to really think about cues that precipitate eating. What kind of things precipitate eating? Is it stress? Is it because you're upset about something?
Watching TV?
Yeah, sitting in front of the TV, sitting in front of the computer. Do you have food with you when you're eating?
Commercials?
Yeah, getting up during the commercial and go getting something to eat. Where are you eating? You should be eating at the table, not in bed, not in front of the computer, not in front of the TV set. Does nervousness, does depression, does loneliness cause you to eat? So you need to really think about what are those cues that's causing you to eat and causing you to overeat. And you need to modify any negative beliefs or behaviors that you have. You need to think about your feelings at the time you are eating. Why are you eating? And as I said, the location. And then what we need to help them do is help them come up with ideas for altering these behaviors, these behaviors that are making them eat. And that's not easy. Modify their negative feelings. It's not easy. Now we're going to talk about surgery. So many people have surgery today. I have probably 6 or 7 or 8 ladies in my church that were very large that has had bariatric surgery. And I think they probably have had gastric bypass, because gastric bypass is the one that's the most successful, and the one that many of the patients who have gastric bypass maintain their weight loss for 5, 10, 15 years. And the ladies in my church that have had it done have lost an unbelievable amount of weight and have maintained their weight loss for a good many years. So that's why I think they probably had gastric bypass. So let's talk about them. There's a couple of different types of procedures. One are your malabsorptive procedures, and the other one is the restrictive procedure. So let's talk about the malabsorptive procedure first. The most common is a gastric bypass, and that's where they actually bypass a portion of the small intestine. And so since they bypassed it, it interferes with the absorption of food. So they're not absorbing as much as they were before, so they lose weight. So rapid weight loss. The stomach, the duodenum, and part of the jejunum are bypassed. And as I said, many of these clients maintain their weight loss for 10 years or more. But there are complications. One of the ladies in my church, when she had her gastric bypass, apparently they did it by laser. They did the little holes in her belly and then went in with a laser and did it. And what happened is they nicked an artery. And so she had to, of course, they had to go in and fix that, and then they had to do blood transfusions, and she had to stay in the hospital a couple of days to recover from that. So there is the possibility of complications. One of the complications that we see sometimes is what is called the dumping syndrome. Have you all heard of that? The dumping syndrome. That comes because the food's moving through the small intestines rapidly, and it's drawing fluid into the intestines by osmosis. Y'all remember that word, osmosis? Miss Atkinson taught y'all osmosis, right? Y'all probably heard it in biology too. And so they have symptoms such as nausea and weakness, bloating, abdominal pain. They feel sweaty, and they can pass out. They also can have nutritional deficiencies from this. Iron, calcium, and vitamin B12 and fat-soluble vitamins. Where's your vitamin B12 absorbed? In the stomach. If they bypass most of the stomach, are you going to have absorption of vitamin B12? So they can have nutritional deficiencies. Iron, vitamin B12, calcium, fat-soluble vitamins. So these folks are probably going to have to be taking vitamin replacements. Okay, let's talk about the restrictive procedures. This is where they put a band around the stomach. That's an example of a restrictive procedure. Has everybody heard of that? Where their stomach is banded? And so what it does is it decreases the volume of the stomach. They can only eat just a very small amount. If they eat more, they're going to throw up. It decreases the stomach volume. However, this is a safer procedure because the food is going into the stomach and it can be absorbed, so they don't have some of the problems that they have with the gastric bypass. The vitamins, the minerals, all that stuff is being absorbed. Normal digestion is taking place. Vomiting is a common post-operative problem, and it's probably because they've eaten too much. And weight loss is often regained with this kind. because these patients are obese and because they're having surgery, they're at risk for complications just simply because they're having surgery and they're obese. They're at risk for thrombophlebitis. They can throw a clot and have a pulmonary embolus. Thrombophlebitis, and they can throw a clot and have a pulmonary embolus. And guess what? You can die from a pulmonary embolus. My best friend in high school died from a pulmonary embolus. She had a little bump in her car, bumped up her knee, and several weeks later, she threw a clot and had a pulmonary embolus and died. She wasn't obese. Okay, and these pictures are in your book, but that shows you the gastric bypass, the banding, and then there's another one. There's two different types of banding. You see the first banding, which is in the middle, is up towards the top of the stomach, and you see how small the little pouch is that it creates. You can see why they can't eat very much, and if they overeat, they're going to throw it up. And then the other one is vertical banding.
I have a question about like the first one. Do they actually remove the stomach when they do that, or do they leave it there? How do you keep from feeling the gurgles and the hunger if you can't actually access it and feel it, or stomach acid? How does that work?
Well, they've just totally bypassed the stomach, and I don't know whether they feel hunger or not. There's problems with gastric bypass. The problems with gastric bypass is because it's almost totally going past the stomach. They're not absorbing their nutrients, and like I said, they have rapid weight loss, but they have nutritional deficiencies. They have dumping syndrome. No, the stomach's still there. It's just bypassed it. Okay. So let's talk about the nursing process. If we have a patient that is obese, we're going to do a health history on them, and we're going to look at their risk factors and their family history. We're going to talk about culture with them. What's their physical activity? Do they have any chronic diseases? What medications are they on? You guys do all that when you get ready to go to clinical, when you get a patient assignment. You ask your patients all those things. We're going to ask them about recent weight gain or loss. And what are their perceptions of their weight and their health? Do they think they're overweight? Do they think they're in good health? And then talk to them about their diet and their food intake. This is really important. Their diet and their food intake. Their eating behaviors, their attitudes towards food. And then you're going to do a physical assessment, physical examination, vital signs, height and weight. You can do those anthropometric measurements that we talked about, which includes skin fold measurements. And the dietitian, you can get the dietitian in on this process. They can actually do the skin fold measurements for you. They can do the BMI. They can do the waist circumference and the waist to hip ratio. All those things that we talked about. Did you know, for you young folks in here, this is something for you to chew on. Did you know that when you, between early and middle adulthood, that most adults gain about 20 pounds? I mean, look at kids that are just coming out of high school or just coming out of college. Most of them are little slim things, aren't they? And then if you could see them when they're 30 or 35, they've gained weight. When they're 40, they've gained some more, 45 a little more. So most adults gain about 20 pounds between early and middle adulthood. Yeah, now y'all can chew on that. Think about it. Okay. And the older you get, the harder it is to keep weight. That's why you need to make sure that you have physical activity, that you include physical activity. All right, let's look at some nursing diagnoses. These are some possible nursing diagnoses: imbalanced nutrition, more than body requirements. We're going to talk about each one of these. We'll talk a little bit. Chronic low self-esteem. Do you think people who are obese might have chronic low self-esteem? Yes. Because we live in a culture that thinks that fat is ugly. Ineffective therapeutic regimen management, they obviously want to lose weight, but they've been ineffective with it. And activity intolerance. Many of these people are so large that when they get out and try to do physical activity, they get so short of breath. So, let's look at our plan. And don't try to memorize these for the test, please. The client will make sensible dietary choices. Don't you think that's a plan? The client will follow their exercise routine. They will relate strategies to deal with hunger. They will attend support group meetings, and they will demonstrate appropriate weight loss. Good. It sounds like good goals. Let's talk about our interventions. We want to encourage the client to identify contributing factors. What is causing you to not be able to lose weight? What is causing you to continue to gain weight? They need to establish realistic goals and objectives. One time I heard somebody say that this person was trying to quit smoking, and he had cut down considerably, but he was still smoking a couple of cigarettes a day, and the person that was working with him wasn't satisfied with that. A realistic goal wasn't for him to quit smoking cold-heartedly. A realistic goal was for him to gradually decrease. So we need to help them establish realistic goals. What kind of knowledge do they have of a balanced diet plan? And we need to discuss behavior modifications, and we need to monitor their weight loss and their blood pressure and their lab data. Exercise program, assess their current activity level and tolerance. They need medical clearance. We've already said that. And as far as a weight loss program, are they willing to incorporate this weight loss program into their lifestyle? If they're not, you're wasting your time. Help them identify behavior modification strategies and help them establish how to deal with stress eating. Do any of you stress eat before the test? Did y'all do that the other night? I bet so. Okay, as far as self-esteem, one of the most important things is to allow them to verbalize. Let them tell you what they're feeling and offer positive feedback and encouragement. And you can refer them to counselors. Remember, guys, we can counsel, but we're not certified counselors. So many times we need to, as RNs, you can counsel. But we're not certified counselors, and we can't make diagnoses. So you need to refer them to a counselor when it's appropriate. And then the last thing is evaluation. We just went through the nursing process, didn't we? Identification and understanding of factors contributing to weight loss. Were they able to do that? Were they able to apply behavior modification techniques to lose weight? Did they accomplish their desired weight loss, and did they incorporate physical activity into their lifestyle? So when you evaluate, you're looking at these things. All right, any questions? And then my last one, y'all love that. Global threat weighting area, obesity. It took me a little while to figure this one out, but I think this means the increased problem that we have with obesity in our country and in the world.
The book said it's the second leading cause next to smoking.
Yeah, it's gonna bypass smoking is what it's gonna do. It's gonna bypass smoking. All right. I have a little case study I want us to work on, and then we're going to talk about thyroid. Because I didn't know that all of you was and this is the obese client. What I want you to do is get with a neighbor, get with a couple of neighbors, and work together to work this through. This one of the reasons I want to do this is because in it asks for you to look at these abnormal labs that this patient has, and I know that you probably didn't bring your lab book, but you can use your phone or your computer to look at the normal sort of labs. We're going to spend about 30 minutes working on this, and then we'll go over it, and then we'll take a break, and then we'll get into thyroid problems. So what happened when I printed it is that it printed the first page and then a blank page. So take both pages because you're going to need the blank page to write out your teaching that you're going to do. So you get 2 pages. So here you go.
Get the blank page.
Here you go. I told you to print 30. I mean 6.
Cholesterol range. Good point.
Diabetes, mellitus, insulin resistance, dyslipidemia, hypertension, and arthrosclerosis, largely due to its secretion of excess additives.
You hear what she said? She said insulin resistance. That's one of the theories. Another theory is resistance to leptin. Remember, leptin we said was a hormone that tells you when you're full, and that with some of these people, the theory is that they have leptin resistance. Your emotions play a part in this. It's very complex. Your appetite is regulated by your central nervous system and also by emotions. Insulin resistance, leptin resistance. Your excess calories are stored as fat. That's, what you take in, you should be burning off those calories. If not, you're going to store what's left. And glucose is stored in the liver as glycogen, and then the fat is stored as triglycerides. Okay, what kind of complications do you think this patient is at risk for?
Heart disease.
Yeah, diabetes is a big one. What else is a big one?
Hypertension.
What?
Hypertension.
Hypertension, cardiovascular disease. Those,
Metabolic.
metabolic syndrome. Yeah. Remember I told y'all to know that? What? There's 4 components of metabolic syndrome. Does anybody remember them? One is hypertension. Yes, increased waist circumference. Yes. And the other one I think is, didn't it increase lipid levels? I can't remember the point. Yeah, there you go. Yeah. So you need to know those. The patient is at risk for postoperative complications. We talked about that. Osteoarthritis, diabetes, heart disease, gallstones, some cancers. We talked about all those. What behavioral changes would you recommend to this patient to incorporate into her lifestyle so to help her deal with trying to lose weight? What are we going to tell her?
Get out of the house, even if it's just to the grocery store, to get out of the house more.
Yeah. Because she's not, is she? She's just sitting in the house all the time. What else? Yes. What
Meal planning.
About her eating habits?
There's a lot of quick healthy
Yeah,
options.
that's a big one, and I don't know that I mentioned that, but I'm glad you mentioned that. We need to teach these folks to read labels. Read labels. Read the fat content, the sodium content, the carbohydrate content, especially if you're diabetic, you need to be reading and noting the carbohydrate content. I read labels all the time. Just let me throw out to you some things that I put on my list, okay? She needs to shop with a list and stick to the list. And you should not shop when you're hungry. Did you know that? If you shop when you're hungry, you're going to fill that basket up. Everything is going to look good. So you should shop after you eat. And I mentioned this, keep all foods in the kitchen, eat in the kitchen or in the dining room. Keep foods out of sight. This is an interesting one. Prepare only the amount of food that you will eat. Don't have any leftovers. That's hard to do, but you can work towards trying to do that. I talked yesterday about eating slowly and chewing. It takes about 20 minutes for you to feel full. Use a small plate. If you have a small plate, you can only get a certain amount of food on it, as compared to a big plate, you can get more food on it. And if you're going to reward yourself, don't reward yourself with food. What's her BMI? What is she? She's obese. Okay, somebody tell me a nursing diagnosis that they identified.
Activity intolerance.
Activity intolerance, okay? I think that might be one that I did too. What are you going to do as far as nursing interventions? No, it's not. What about activity intolerance? What are you going to do?
You could show her some basic stretches that help with the area she's in pain with.
Okay. What else are we going to do?
Develop a exercise.
Yeah, especially if she's short of breath. She said spread her ADLs out throughout the day, and especially if she's short of breath. This woman is sitting on the couch doing nothing but eating and watching TV and sitting in front of the computer, and she's not getting any exercise at all. So she's probably going to get pretty easily fatigued when she starts exercising. So she's going to have to build up her stamina. So she's going to have to start slowly. So that might be a good way to get her to start, get her to get up off the couch and do some things in the house, but spread it out throughout the day. And then, of course, what did I tell you was the best aerobic exercise? If she can find her a partner to walk with, someone to walk with, and just walk around your neighborhood. What about another nursing diagnosis? Chronic pain. Okay, and she had an accident, didn't she? She's got back pain. And that's one reason why she's become so sedentary. So what are you going to do as far as nursing interventions for her pain? Alternative therapies. Yeah, and we might encourage her to talk to her doctor about making an appointment with pain clinic. Okay. Did anybody do imbalanced nutrition more than body requirements? Mm-hmm. Yeah. Yeah, that's a really good one. What are some interventions for that?
Food diary.
Food diary, absolutely.
We did excessive food volume related to sodium intake.
Yeah, oh my mercy, yeah, all that snack food that she's eating, and you know that she's probably holding on the fluid. Yeah.
Since she doesn't like
a good intervention for that one would be teaching her about sodium and what it does to the body, and teaching her the proper amount of sodium that she needs a day. Do you know you only need about a teaspoon of sodium a day? I think it's like 220 milligrams.
The allowed 15 to 23.
Yeah, and you need to teach her to read labels.
And also, that's some good stuff. She's not going to make water, just drinking like coffee,
Yeah, the thing about water is that water is hypotonic, and and so we don't want her to overdo with water. Y'all remember fluid and electrolytes? The tonicity of whatever you're drinking, and water is hypotonic. So yes, water is good. You need to drink about 8 to 10 glasses of water a day because it flushes out the system, but we don't want her to overdo it. Let's look at those lab values. Let's talk about them for a minute. Okay, what was her cholesterol? 220, is it elevated? What's normal? I'll put it up here. Less than 200. I think yesterday I gave you a range of, I think, about 130 to 200. Didn't I tell you that? So we want it less than 200. What makes your cholesterol go up? What's she doing? What's she eating that's making her cholesterol go up? All those saturated fats and trans fats in that processed food that she's eating. Yeah. What about her HDL? That's the good cholesterol. What was it? So it's low, isn't it? Hers should be greater than 55. Why do you think it's low? Yeah. Right. Right. Did you know that if you exercise, that it increases your good cholesterol? If you get on a regular exercise program, it will increase your good cholesterol. So her sedentary lifestyle is one of the things that's made her HDL be so low. Her LDL is her bad cholesterol, and it's what? 160, and it should be less than 130. What causes it to be up? All those fats she's consuming, high cholesterol diet, all those fats. And the lack of exercise also can make it go up. So, remember in 101 when we talked about teaching and learning? And now we're going to teach this patient about changing her lifestyle, about getting on her diet, about exercising. What's the first thing we need to do? When you teach somebody, what do you want to think about first?
What do they already know?
That you want to do that. Absolutely. You want to think about the way you can talk to them about the way you learn. How do you learn best? But the first thing we want to do is look at her developmental age. Where is she developmentally? Because if you've got an adult, you're going to approach your teaching sessions different from if you had, say, a teenager or an 8 or 10-year-old child. So you want to think about their developmental age. Yes. And we also need to think about what their previous knowledge is. What does she have? Because we want to build on that knowledge, don't we? Mm-hmm. And then we're going to select appropriate teaching strategies. And so then we're going to do all the things that we've talked about. Teach her about lifestyle changes, behavior modification, sticking to her diet, healthy eating, exercise, all those things. And that she needs to be under the care of a physician. And we can talk about some of those alternative things that you talked about. Yoga, meditation, those kinds of things that might work for some people. And support groups also. Okay, why don't we take a 15-minute break? Let's see. I've got 10:55. Take a 15-minute break, so come back at 15 after and we'll start on thyroid problems.
And like their login and stuff.
Like, you guys don't have that information anymore. I mean, I've been wanting to get a match. We had it for that no month training. Really? I have short torso. And I think my arm is a little bit.
Clinical prep.
Yeah.
I bought this doctor.
I don't know how to Well, it's on pause. I don't know how to stop it.
Hey, Rosa, are you in my group review it? Remember the hypothalamus that we talked about that's in the brain? the hypothalamus releases TRH, and that is thyrotropin releasing hormone. And that hormone stimulates the anterior pituitary gland to release TSH, and TSH is thyroid stimulating hormone. And thyroid stimulating hormone stimulates the thyroid gland to release T3 and T4, to produce and release T3 and T4 into the bloodstream. And those are the thyroid hormones, and that's what you need. The thyroid, all of this is controlled by the hypothalamus. And the thyroid hormones maintains metabolism in the body. If you have too much thyroid hormone, what happens to the metabolism? It goes up and you have hyperthyroidism. If you don't have enough thyroid hormone, your metabolism goes down, and what you're going to see when we talk about these signs and symptoms is that they're almost exactly opposite. Not totally, but almost exactly opposite. So, when you have a patient that has hyperthyroidism, they have excessive thyroid hormone secretion from the thyroid gland. That process that I talked about there's a balance. If the body senses, if the hypothalamus senses that there's too much thyroid hormone being produced, then it will not release that hormone. If it senses that there's not enough, then it will release that hormone, that TRH, which is thyrotropin releasing hormone, which stimulates the anterior pituitary gland to release TSH, which stimulates the thyroid gland to release T3 and T4. So it's a balance. Okay. You also need iodine in your diet to produce those thyroid hormones, and that's why we all buy salt that's fortified with iodine, because there's some parts of the country that do not have very much iodine in their soil. Okay? So, if you've got too much thyroid hormone and the metabolism is increased, these are the symptoms you're going to see. Everything is going to be increased. Everything is going to be increased. They're going to have increased heart rate and the stroke volume. Their cardiac output will be increased because their heart rate's increased. They'll have increased systolic blood pressure. Now, these people are going to be hungry, and they're going to be eating. They're going to be just eating, and they're going to have protein buildup. But their protein is being broken down faster than they can build it up, so they end up in negative nitrogen balance. So they're hungry, and they're losing weight. They're hyperglycemic. One of the reasons why they're hyperglycemic is because this increased amount of thyroid hormone stimulates the sympathetic nervous system, and so it causes hyperglycemia. And it's also due to insulin resistance. Remember, we talked about insulin resistance. Decreased body fat because of the breakdown of everything, because the metabolism is so increased. Increased appetite with weight loss, we said that. Women will have menstrual problems and decreased fertility, and there's increased libido in both sexes. Now, before I go any farther, let me tell you that hyperthyroidism is rare in children. If you do see it in a child, it's usually diagnosed when they're adolescents. And what will happen is, by the way, it's thought to be an immune process in children. Okay. Let's look at some more signs and symptoms. Okay, these folks are going to have increased stools. They're going to have diarrhea. When we talk about hypothyroidism, we're going to talk about constipation because everything's slowed down. When we talk about those symptoms, you're going to think back to what we talked about for the symptoms of hyperthyroidism, and you're going to see that they're almost opposite. They're intolerant to heat. Look at that handout I gave you. Look at that handout. You see she's got the fan blowing on her? She's hot all the time. They're very intolerant to heat. So you don't want to put them in a warm room. They need a cool environment. And they're diaphoresing all the time. They're sweating. They have palpitations and chest pain. Increased metabolism is causing the heart to beat faster. They'll have palpitations. They'll have chest pains. They'll have dyspnea, difficulty breathing. By the way, hyperthyroidism is called Graves' disease. And they'll have exophthalmos, and that is the bulging of the eyes. And it's due to periorbital edema. Oh, we have an accident. Yeah. Okay, so they have periorbital edema, and it presses on their eyes, and so their eyes will bulge. And as a result, their eyelids sometimes have difficulty closing, and so their eyes will become dry, and they can get corneal ulcers. And so we'll talk about the nursing care for this when we get to the nursing care, but we'll be very specific about what we're going to do about their eyes. Many times they have blurring and double vision and photophobia, fatigue, muscle weakness, insomnia. Why do you think they have insomnia? Everything's revved up. They're so restless. They can't get settled to go to sleep. And so the next one is irritability, restlessness. Many times they have thyroid enlargement and they'll have a goiter. You'll see that in hypothyroidism and also hyperthyroidism, they'll have a goiter many times. When you take the stethoscope and listen to their thyroid gland, you will hear a bruit. And a bruit is a swishing sound. Because of the increased cardiac functioning, the increased heart rate, all that, they'll have dysrhythmias. Hyperactive deep tendon reflexes, warm, moist skin, and their hair becomes very fine and soft and silky. Now, I told you that you very rarely see this in a child, but if you do, you usually see it in adolescence. And if you do see it in a child, because of the increased metabolism, they will have accelerated growth and advanced bone age. Advanced bone age, Their bones will be growing faster than their age. Okay, let's look at the etiology. I told you that it's called Graves' disease. Graves' disease is the most common type of hyperthyroidism. And Graves' disease is considered an autoimmune disease. Another cause of hyperthyroidism can be that they have thyroid nodules. It's usually an adenoma that can cause hyperactivity of the thyroid gland. Adenomas. Also, thyroid replacement hormones can cause hyperthyroidism. But we're going to focus on Graves' disease because it's the most common. And when you go take Netflix, what do you think Netflix is going to ask you?
Graves'
They're
disease.
going to ask you about the most common things. So they're going to ask you about Graves' disease if they ask you about this. Yeah. So, as I said, it's an autoimmune disorder. And what happens is immunoglobulins attach to the thyroid tissue, and the thyroid gland responds. And what happens is they have an increased number of thyroid cells, and they can have a goiter. And so a goiter is very common with Graves' disease. And as a result, they have overproduction of the thyroid hormones. And I talked about the exophthalmos. That's pretty specific to Graves' disease. The bulging of the eyeballs, they have periorbital edema. That's what's causing the bulging of the eyeballs. Okay. Look at the incidence. In women, 20 to 40 is when you see Graves' disease. It's more common in women than in men. And the nodules, the adenoma borders, you see after age 50, and it's most often in women than in men. So women are the ones that have thyroid problems. There also seems to be a genetic predisposition to thyroid disease in some families. It is in my family. It passed me. It missed me, but my mother had it. My sister has it. My father had it. My grandmother had it. And so there seems to be an increased incidence in some families for thyroid problems. If you have Graves' disease, and I told you that Graves' disease is an autoimmune disease, then you are at increased risk for developing some other type of autoimmune disease too. All right, let's talk about the lab things that you're going to see. Okay. There we go. Okay. The ones I want you to remember is T3, T4, and TSH. In hyperthyroidism and Graves' disease, the T3 and the T4 are elevated, and the TSH is low in Graves' disease. Why do you think the TSH is low? That's right. You already are producing all this thyroid hormone, so the hypothalamus has sensed that, and so it's not sending out that hormone that's stimulating the anterior pituitary gland to produce TSH, so your TSH is going to be low. Your TSH may be high in secondary or tertiary hyperthyroidism, and that just means that it's a type of hyperthyroidism that the cause is outside of the thyroid gland, because with Graves' disease, the cause is the thyroid gland. The thyroid gland is producing too much T3 and T4. Secondary and tertiary means that the cause is outside the thyroid gland. It's either in the anterior pituitary or the hypothalamus. And then this is very simple to remember. The antibodies to TSH, they're going to look for that if it's Graves' disease, because that indicates that it's Graves' disease and that it's an autoimmune disease. Because with an autoimmune disease, you're producing antibodies to the antigen. Have y'all talked about antibodies and antigens yet? Yeah. Did you have it in biology?
Yes.
Okay. And you know, an antigen is something that your body responds to and creates antibodies. So with this, the body is seeing the thyroid gland as foreign and producing antibodies.
I'm sorry, can you repeat the whole thing with the antibodies and the TSH?
I'm sorry.
Can you repeat that antibodies and TSH?
Yeah, you're going to see. They're going to look to see. They're going to look at the blood to see if there's any antibodies to TSH, and if there are, then that helps them diagnose Graves' disease. Okay, let's look at other diagnostic tests. One of the things that they may do is a thyroid scan, and a thyroid scan will evaluate the size and the position and the functioning of the thyroid gland. Now, they give them radioactive iodine to do this test. They give it to them by mouth. And what they measure once they give them the radioactive iodine is how much of that iodine that the thyroid gland takes up. And the uptake is increased with hyperthyroidism. Now, there's no radiation precautions with this, but you don't want to use this test on a pregnant woman. A female that's pregnant, you do not want to do this test. They also may do an ultrasound of the thyroid gland, and if any of you've seen the ultrasounds, you know they just take the machine and they have the gel and they put it over the area to be assessed, and they run it back and forth over that area. So this time it would be over the thyroid gland, and again it tells them the size, and they can see masses and nodules. There's no preparation for this, and there's nothing that you have to do afterwards. And then an electrocardiogram or an EKG or an ECG, whatever you want to call it. I'm from the school that calls it EKG. They're going to do that because, remember, we talked about that a lot of the signs and symptoms are cardiovascular, the increased heart rate and all that, dysrhythmias. So they want to look at the EKG to see if there's any changes in the EKG. Hopefully they'll have a previous EKG that they can look at that they compare this one with, but they're looking for dysrhythmias, tachycardia, those kinds of things. Questions up to this point? Has anybody got any questions? Okay, then let's talk about the medications that we're going to use to treat it. Okay, there's two antithyroid drugs that they use. One is propylthyricin. I'm not sure I'm saying that right. PTU is an acronym for that. And the other one is methimazole, which is tapazole. Both of these drugs inhibit the incorporation of iodine atoms into T3 and T4. And remember I told you had to have iodine to produce T3 and T4? And because this patient is producing too much T3 and T4, these medicines will inhibit the taking up of iodine into the thyroid gland, so it will decrease the production of T3 and T4. So, things you need to know about these. Both of them decrease the immune response. So you need to teach these patients while they're on these drugs, because they're not going to be on these drugs for an extended period of time. Because these drugs are essentially going to, actually they can leave the patient to where they're not making any T3 or T4, and they'll become hypothyroidism. So that's one of the problems with these drugs. So they're not going to be on these drugs for a long period of time, but you need to teach them while they're on them to stay away from crowds and stay away from sick people. You need to monitor them for signs and symptoms of hypothyroidism with both of these drugs. Now, I'm going to tell you two differences. With PTU, this drug can cause liver failure. So you need to monitor liver enzymes with this drug. And you need to be monitoring this patient for any signs of liver failure, like yellowing of the sclera, those kinds of things, darkening of their urine. The other one, tapazole, can cause birth defects, so you do not give it to a pregnant female. This drug is not appropriate for a pregnant female. Make sure you know those. Everybody hear me? Make sure you know those. Okay, we're going to move on. Now we're going to talk about a few more antithyroid drugs. We're going to talk about radioactive iodine. It's I-131 is actually what it is. This is a radioactive product, so we need to take radiation. We need to teach this patient to take radiation precautions, and I'm going to tell you about those in a minute. But this one will destroy the cells of the thyroid gland, and for sure this one is going to increase the risk of the patient becoming hypothyroid after, and they may require thyroid replacement hormones for the rest of their life. Let me tell you some stuff about this. You don't use it in a pregnant woman because it can harm the fetus. The radiation is usually eliminated from the body within about a month, but they have to take radiation precautions during that month, and I'm going to tell you some in a minute. The radioactivity is stored in the patient's body fluids for a few weeks after therapy, and that's one reason why you need to take precautions. They need to, males and females need to sit to urinate. If urine is splashed on the commode, they need to clean it up with paper towels and then put them in a plastic bag and take them to the hospital, to their radiation center. There's some other things I'll tell you in a minute. They have to be monitored regularly after this for signs and symptoms of changes in their thyroid function. All right. They need to flush the toilet 3 times after they use the toilet. They need to do these things for about a month. Remember I said females and males need to sit. And if they get urine on the commode, they need to clean it up and take it to the hospital's radiation department. They need to wear machine washable clothing and wash them in the machine, and then after they wash them in the machine, they need to run the washing machine with nothing in it just to wash the machine out. They need to avoid close contact with pregnant women and with children for several weeks. And because this need to avoid contact with pregnant women and children for several weeks. And because this radiation activity can be in their saliva, they need to not share their toothbrush. They need to use disposable utensils like plates, cups, and spoons and forks and knives. But after about a month, they're okay. By the way, this is in your book, if you want to look at it. Your Iggy. Okay, Lugol solution is another type of iodine that we can give our patients. This is not radioactive, and it's given to suppress thyroid function, but one of the main reasons we give this one is to suppress the vascularity of the thyroid gland if they're going to have thyroid surgery. Because the treatment for hyperthyroidism is either medication or surgery. And sometimes, if they have a huge border, or if they have an adenoma, then they have to have surgery. And so we're going to talk about surgery and make sure you know this stuff. Okay. Some other things that I don't have up there, let me see. Yeah, I do. Lithium is another drug that may be used if a patient is hyperthyroid. Your beta adrenergic drugs like propranolol, which is Inderal, to help decrease the cardiovascular effects that we've talked about. Those help sometimes. Your lithium also will inhibit thyroid hormone release, but they don't use that a lot because of its side effects. Your beta adrenergic blocking drugs are real important if patients are going to have surgery because you've got to get those cardiovascular effects under control before they have surgery.
So it's used to decrease the cardiovascular effects?
Yeah, because they have increased heart rate, they have increased blood pressure. We need to get those things under control before they have surgery. And also because the thyroid gland is very vascular, and because they can bleed easily, we give them the Lugol solution to decrease the vascularity of the thyroid gland so that they don't have as much risk of bleeding postoperatively.
So that would be vasoconstriction.
Well, it just decreases the vascularity. Okay. All right, so let's talk about the surgical approach. I've got a total thyroidectomy. They may have a total thyroidectomy where they take out the whole thyroid gland, and if they do, of course they're going to have hormone replacement, thyroid hormone replacement for the rest of their life. But they may just have what is called a subtotal thyroidectomy, and I don't have that up there, so you can just write that in. And so if they leave part of the thyroid gland in, then the remainder of the gland can produce thyroid hormone. So let's talk a little bit about the surgery because it's very involved and complicated. First of all, we talked about the antithyroid drugs. They give those antithyroid drugs before surgery to get that thyroid hormone secretion under control, because you don't want them to go into surgery with all that thyroid hormone floating around in their bloodstream. And they give them the iodine, as I said, to decrease the vascularity. Okay, so now they've had surgery. They also are on a high protein, high carbohydrate diet. Also, you need to teach the patient how to support their neck, because they're going to have a surgical incision here, and it's going to be different. They're going to have trouble moving their neck, so you can teach them to support their neck postoperatively like this, because you don't want them to put any strain on that incision. Now they can move their neck. I'm not inferring that they can't move their neck, but you just need to teach them that when they're moving around to support their neck. Okay. Alright, so postoperatively, this is what we're going to monitor. We're going to monitor vital signs every 15 minutes until they're stable, and then every 30 minutes for 24 hours. That's pretty standard for postoperative care. Have y'all had surgery yet? No. Okay. Well, that's pretty standard. Every 15 minutes until stable, and then every 30 minutes for 24 hours. For pain, we can give them sandbags or pillows to support the head. They need to be in a semi-Fowler's position. As again, we teach them how to support their neck because we don't want any tension on that suture line. They should avoid neck extension. And of course, we're going to give them medication for pain. That goes without saying. Now, these patients may hemorrhage, so we need to monitor them for hemorrhage. So not only are you looking at the dressing, but you're looking back here too. Where does blood flow? Down. It flows by gravity. So this right here, this dressing may look okay, and then you may turn them over and you may have a puddle of blood under their neck. So you need to monitor them for hemorrhage. Inspect the dressing behind the neck for bleeding. Serosanguinous drainage is normal. Serosanguinous is little blood tinged drainage. You're going to see some bleeding postoperatively, but after a day or so, it should stop. And you're not going to see a lot of bleeding. It's going to be serosanguinous. If they're hemorrhaging, it can cause compression on the trachea, and they can have trouble breathing. So we need to monitor their respiratory status. We want them to cough, turn, cough, and deep breathe every hour. We can suction them if we have to. We hope we don't have to. This is important. You need to monitor for laryngeal stridor. That's a high-pitched sound when they breathe, and it indicates a respiratory obstruction. The larynx and the laryngeal nerves could have been damaged during the surgery. And if this occurs, they may need an emergency tracheostomy, so you need to have a tracheostomy tray right by their bedside. Very, very important. A tracheostomy tray right by their bedside in case they have trouble breathing, if there's damage to that laryngeal nerve. You need oxygen. Now, let's talk about hypocalcemia and tetany. Y'all remember fluid and electrolytes? Remember hypocalcemia? Remember tetany? What can happen is that during a thyroidectomy, the parathyroid glands, which lie right behind the thyroid gland, can be either accidentally removed or damaged. And what happens if they are either removed or damaged is that you have decreased parathyroid hormone production. And as a result, you have decreased amount of calcium in the blood. And so you know that with tetany, they have a decreased calcium level. Does everybody remember that? And they have positive Yost sign and positive Yost sign. Everybody remember that? Okay. And they may complain about tingling around the mouth and in the toes and the fingers. Okay, I'm not sure. Okay, I didn't have that. I thought I had a picture of Trousseau's and Yost, but I don't. And so what can happen is they can have cardiac dysrhythmias and they can die. So what we're going to do is if they have tetany, what are we going to give them? Does anybody remember from fluid and electrolyte? What are we going to give them?
Hypertonic solution. Hypertonic solution.
What medication are we going to give them? We're going to give them something IV.
Sodium bicarbonate.
Calcium carbonate. Y'all remember that? Calcium carbonate. We're going to give them IV. Now, they definitely need to be on a monitor if they're getting calcium carbonate, because you need to monitor this drug very carefully because they can have some bad side effects. Okay, and getting back to the laryngeal nerve damage, they also may have hoarseness and a weak voice if their laryngeal nerve has been damaged, so you need to assess their voice every 2 hours. So make sure you know all that stuff I just told you. And then we're going to talk about thyroid storm, and you need to know this one too. Thyroid storm is rare, but it can occur after thyroid surgery, and it's where excessive amounts of thyroid hormone have been released into the bloodstream, and it comes from manipulation of the thyroid gland during surgery. Excessive amounts of thyroid hormone has been released into the bloodstream, and it is caused by the thyroid gland being manipulated during surgery. This is life-threatening, and what they have is an uncontrolled hyperthyroidism. And what do you think happens if it's uncontrolled hyperthyroidism? What happens to the metabolic rate? It's greatly increased. It's greatly increased. And so they have a very high fever, 102 to 106 degrees Fahrenheit. They have tachycardia, severe hypertension.
Excuse me. Excuse me.
Bless you.
Thank you.
And they can have seizures and go into a coma and die. So what do you think we're going to do to treat them? First of all, we're going to put them on a cooling blanket. Does that make sense? We want to get that temperature down. We're going to put them on a cooling blanket. Of course, we're going to start an IV. We want to give them fluids. Fluids will also help cool them off. But one of the first things we want to do is make sure that we maintain airway patency. That is the first thing you want to do. Maintain airway patency because they can go into respiratory distress. We're going to give them antithyroid drugs, the ones we just talked about, PTU and tapazole, but tapazole is the preferred drug. Remember the propranolol that I talked about earlier to help decrease those cardiac symptoms? We're going to give that IV. We're going to give glucocorticoids if they're prescribed. Remember, how many of you have given glucocorticoids in the clinical area? Anybody? Glucocorticoids are anti-inflammatories, and so these will help. We're going to monitor their cardiac status, monitor for dysrhythmias, monitor their vital signs. Now, we're not going to give this patient aspirin for their fever because aspirin will increase the free thyroid hormone, so it'll make it worse. So we're going to have to give them something else for fever, like ibuprofen. So in doing all of this, hopefully we've stabilized the cardiac function, the cardiovascular function, the respiratory function. We want to monitor electrolytes. What electrolytes do you think we're going to monitor?
Calcium.
The calcium and also the magnesium. Do y'all remember from fluid electrolytes that if the calcium's up, the magnesium's low, they have a reciprocal relationship and vice versa? So you want to monitor both of those electrolytes. Okay, let's talk about nursing care. We probably aren't going to get to finish all of this today. Okay, let's talk about. I think I'm. There we go. That's the one I wanted. Does it make sense to you with all these cardiac things going on? The increased heart rate, the increased stroke volume, the increased cardiac output, that over time they could have decreased cardiac output because of the dysrhythmias and because the heart's pumping so hard, and eventually they can have decreased cardiac output. Does that make sense? Yes. Okay. So we want to monitor so one of our nursing diagnoses might be decreased cardiac output. So we want to monitor their cardiovascular status, monitor their respiratory status, monitor their temperature. We want to reduce stimulation because they've already got all this T3 and T4 that's stimulating them. So we want to have them in a quiet environment and limit visitors. And of course, we're going to administer their medications. Now, not every one of these patients are going to have surgery. So if you have a patient that has not had is not scheduled for surgery, you're going to be administering those antithyroid drugs, and if they're going to have surgery, you're also going to be administering them. So you're going to do pre and post-op care for those that are having surgery, and we've talked about that, so we don't have to go back into that. Okay, let's talk about nursing care. Let's talk about what about another nursing diagnosis? Disturbed visual sensory perception because of the exophthalmos. And remember we talked about that because of the periorbital edema, the eyes are bulging, their eyelids may not be able to close, their eyes become dry, they can develop corneal ulcers. So what are we going to do? Artificial tears, dark glasses, eye patches. You can actually tape the lid shut. Did you know that? At night when they're sleeping, you can actually tape, or before they go to sleep, you can tape their lid. You can tape them shut.
What did you say the diagnosis was? Disturbed visual?
Disturbed visual sensory perception.
Thank you.
Remember I told you that it's caused by the periorbital edema. They may put them on corticosteroids for a short term to reduce that swelling. and also diuretics to reduce the edema. Before we get to teaching, let me talk about imbalanced nutrition. I don't have this one up there. Remember we talked about they're eating, but because their metabolism is so revved up that they're breaking down protein, and so they're faster than they can build it up, so they're in negative nitrogen balance. So they may have imbalanced nutrition, so you need to monitor their nutritional status. And of course they're losing weight, we said that. Monitor their weight daily. And teach them about their diet. They need to have a high carb and a high protein diet. And they need between meal snacks, and they need to avoid alcohol, coffee, tea, and colas. They need to forget the alcohol. They need to avoid coffee, tea, and colas. Why do you think they need to avoid those?
Caffeine.
The caffeine, and that stimulates them. And then we need to teach these patients. Many of these patients are going to become hypothyroid, so we need to teach them that they need to follow up with their physician because their thyroid functioning needs to be monitored. They may need to go on thyroid replacement therapy. And if you have a patient that's had surgery, then before they go home, you need to teach them signs and symptoms of infection and when to contact the physician. Questions about hyperthyroidism? Make sure you know hyper and hypo for the test. Okay. Let's just start talking about hypothyroidism, and we'll quit when it gets to be 12 o'clock. I know y'all are ready to go. Okay. With hypothyroidism, we have the opposite. We have low levels of thyroid hormone, and the metabolism is decreased this time. Hypothyroidism in adults is called myxedema. Myxedema. Hypothyroidism in children is called cretinism. Remember yesterday? Cretinism. Cretinism. Hypothyroidism in children is called cretinism. Remember I told you yesterday that if a child is hypothyroid at birth, if it's not identified immediately, then they have growth and development deficiencies, and they also will become mentally retarded. And there's a picture in your book, I think, that shows a person who is a cretin, and I mean that is the typical textbook picture of a person who has cretinism. Myxedema. Myxedema. All right, let's look at the signs and symptoms, and I think it'll be time to go. Okay. What they have, we talked about myxedema. That's a mucinous edema. And you see the next 1, 2, 3, 4, the next 4 things, those should be under myxedema. Because when they have myxedema, they have a non-pitting edema all over the body. They have edema, but it doesn't pit. They have a thick tongue. They have a husky voice due to the edema of the larynx. And they can actually go into a myxedema coma and die. That's if you have severe, long-standing hypothyroidism that's not been treated. They have a flabby, enlarged heart and decreased cardiac output and decreased tissue perfusion with myxedema. They also will have increased sleeping time. They're so lethargic. They're weak. They're anorexic. They have no appetite.
This for both? This for both?
Mm-mm.
Just the myxedema?
Mm-hmm. No, we're talking about hypothyroidism. But the myxedema comes under hypothyroidism, but the next 4, 1, 2, 3, 4, that's describing myxedema. I should have indented all the next 4. So put yourself an arrow or something to indicate to you that comes under myxedema. They're constipated. Remember, with hyperthyroidism, they have diarrhea. They have loose stools. They're very cold all the time. Remember, with your hyperthyroidism, they're hot. They have intolerance to heat, and they have decreased libido. I think we'll stop here. And tomorrow we'll start up, and we'll also get into